So now that we've reviewed the mouth, the sino-respiratory tract, as well as the genitourinary tract, we still have before us tissue, parenchymal, and blood dysbiosis, cutaneous dysbiosis, environmental dysbiosis, and that is, of course, before we get into gastrointestinal dysbiosis, which will be the largest and most complex presentation on dysbiosis by location, because, of course, the gastrointestinal tract is our largest source of microbial exposure. And also within that gastrointestinal tract, we see many different patterns of dysbiosis. In most other areas, we don't see quite so many patterns. For example, in the sino-respiratory tract, we might see 2 or 3 different patterns of dysbiosis. In the gastrointestinal tract, we see many different types of dysbiosis that can have clinical consequences. Therefore, as we review each of these other dysbiotic locations, we're kind of using that to introduce certain topics that we'll again revisit when we talk about gastrointestinal dysbiosis, because gastrointestinal dysbiosis is definitely the culmination of anything and everything that can go wrong, and that will be more clear, of course, as we go through that presentation. What we're going to focus on right now is category number 1 on this list, which is tissue, blood, and parenchymal dysbiosis. So, of course, what I want to focus on here are the areas that are most actionable and most clinically relevant. So we're going to look at specific microbes as relevant to this topic of tissue, parenchymal, or blood dysbiosis. So, again, what I'm trying to avoid is too much theory, because I think a lot of articles and a lot of blogs, for example, a lot of information you can read on the internet has theory, but it doesn't have specificity, and it certainly doesn't have peer-reviewed application. So what I want to do in this presentation, and the way that I prepared it, is to focus on some really key examples that we can kind of set our hooks into, or set our anchor into, so to speak, and where we can really feel like we're grounded in this information, not kind of swimming around with a bunch of theory that may or may not be relevant and may or may not be well proven. We do have some really clear examples that I'm going to emphasize here that are well proven, and we've got good actionable data. And that's going to be the emphasis of this presentation. So in the book, especially the bigger book now, Inflammation Mastery 4th edition, which is also now available in 2 different volumes, but the major textbook, as far as I'm considered, is Inflammation Mastery 4th edition. In that book, as well as in a previous publication, Antiviral Strategies, I talk about viral infections. Obviously, viral infections are a form of tissue or parenchymal dysbiosis, we might say, because a lot of these viral activation states are not true infections, but the virus remains more than simply dormant. It remains a little bit active, constantly perpetuating and triggering an inflammatory and immune response, but not such a vigorous response that the immune system is actually then able to eliminate the virus. A lot of these viruses, for example, herpes simplex type 1, type 2, Epstein-Barr virus, cytomegalovirus, these are all in the herpes family. And so these are viruses that people have pretty much for the rest of their lives. The issue then becomes, can we keep those viruses in their dormant state? And in a lot of patients, they don't have overt infection, and they don't have complete dormancy of those viruses. The viruses are what we might call semi-activated, so that they're not causing overt infection, but they're still causing some damage. And so the goal there, of course, is to get those viruses back into their dormant state so that they're not triggering this chronic immune activation and the inflammatory consequences that we expect and that we see clinically. For example, in Alzheimer's disease, we see a pretty good correlation between Alzheimer's disease and herpes simplex type 1 activity. Patients with higher levels of herpes simplex 1 antibodies, indicating higher levels of viral activation and activity, do have increased risk for Alzheimer's disease. And so we do see a correlation between levels of viral activation and clinical disease. Again, that's mentioned in the book Antiviral Strategies, which is available as a paper book as well as in a digital book. All of that same material, the exact same material, is in the updated version of Inflammation Mastery, published in 2016 in the 4th edition. So when we talk about, or when we think about tissue or parenchymal dysbiosis, we definitely need to think of viral infections. I'm not going to cover that here. It is covered in some of my other work, but here I mostly want to focus on bacteria. So having said that, let's go through this brief list of notable viruses as I state here. Epstein-Barr virus associated with Sjogren's syndrome, lupus, as well as scleroderma. Parvovirus B19, Sjogren's syndrome, lupus, scleroderma again. And same with cytomegalovirus, Sjogren's syndrome, lupus, and scleroderma. Herpes simplex, as I mentioned previously, associated with Alzheimer's disease. Algal virus associated with human dementia and just slower cognitive function in general. And of course, what I call here the major viruses, or what we might call the major medical viruses, hepatitis B virus, hepatitis C virus, and of course HIV. Those are long-term persistent chronic infections. Now let's focus on some bacteria that appear to play a role relevant to this conversation, again, as I categorize them as tissue parenchymal or blood dysbiosis. So in this case, we're talking about the presence of bacteria in living tissue, but not an overt infection. So we talk about inflammation-triggered or microbe-triggered arthritis, but we're not talking about septic arthritis. We can see that some patients carry these microbes within their nasopharyngeal passages, but we're not talking about a sinus infection or a throat infection or pneumonia. We're just talking about kind of a low or intermediate grade colonization that causes perpetual immune stimulation, a perpetual inflammatory response, but not such a vigorous response that it's associated with tissue damage, and also not such a vigorous response that it actually leads to clearance of the microbe. So these microbes get to kind of perpetuate themselves in a low-grade colonization state that doesn't trigger an aggressive immune response that leads to clearance of the bacteria. So you can see, obviously, this is a strategy used by the microbes where they colonize and are able to persist, but they colonize at such a low level that they don't instigate an appropriate immune response or an effective immune response that leads to their clearance, because obviously they're trying to kind of hang on for a free ride, so to speak. So as I state in the first paragraph here, in this presentation I'll focus on persistent bacterial infections, or colonizations I might say, that induce inflammatory autoimmune disease. I'll focus on reasonable assessments and reasonable treatments per the biomedical research and medical practice. Obviously you've got some leeway there. You can do more testing if you want. You can use different types of treatments. I'm just going to show you what's representative in the research literature that I think we could use in our practice in a defensible manner. So when I say that, what I actually mean comes from my own experience. For example, when I first started practicing, I practiced for a little while in Seattle, Washington, but then I practiced for about 6 years in Houston, Texas as a naturopathic doctor, but mostly under my chiropractic license. So basically what I had to learn to do in that setting was practice very defensively, because the Texas Medical Association is very aggressive against naturopathic doctors and against chiropractors. So my way of practicing was that I had to have, for my own standards, I had to have good research backing everything I did in case I ever got called in front of the very aggressive Texas Medical Association. I wanted to always be sure that I had data that I could present. So I'm kind of using that same model of defensive practice when I write my books and when I give my presentations. What could we do that's not simply justifiable, but what could we do that's actually defensible if we were to get called in front of a medical review board? And you'll see that that's the standard that I use here. I also don't specifically cover Lyme disease because I kind of consider that to be a specialty or subspecialty infection or a clinical condition. Obviously, Lyme disease has a lot of complicating factors, viral as well as bacterial. Those patients typically have many different co-infections, Babesia, for example, and others as well. I don't get into Lyme in my clinical practice, and I don't cover it in my teaching materials either. Let's talk about antibiotic drugs. So again, the infectious disease approach, or the conventional standard medical approach, is identify the microbe and then target that microbe. We're going to see where that approach has some strengths, and we also see, of course, where that approach has some weaknesses. So when we talk about antibiotic drugs, we need to discuss them in the context of citations and clinical applications, things that have been published, certain guidelines, certain substantial research articles, for example. Obviously, appropriate choice is determined by the microbe, the disease, patient tolerance, allergy, renal function, drug interactions, etc. Dose and duration are determined by the published data and patient-specific scenario. Obviously, many antibiotics can be used for different microbes. Rather than qualify and prolong each discussion, I'm simply going to describe the recommended course of action per the research that I'm reviewing here, which I think is best represented by the published data. And then clinicians, of course, can make changes as they need to. And when we talk about using antibiotic drugs in this context, we have to appreciate that we're not using the drugs in the same way that we would if we were treating an acute short-term infection. So, for example, in the treatment of strep throat, we might use a penicillin-derived antibiotic for 5 to 10 days. However, when we're treating chronic colonization of the nasopharynx, we tend to use antibiotics for much longer periods of time in terms of months and years. You'll see that some of the research, which I think is really important in this area, has used penicillin-based antibiotics or an alternative such as azithromycin, not simply for a matter of days, but actually for months and years to clear these colonizations and dysbiotic relationships. So we have to look at these infections differently, and we have to look at these colonizations differently when we're treating dysbiotic type responses rather than the textbook perfect short-term infections that we all learn in medical school. We learn about strep throat, we learn about pneumonia, but we don't learn about long-term persistent colonizations. As I state toward the bottom of the page, my personal and professional opinion is that we have to kind of get over, literally, the classic microbe disease associations that we all learn in basic sciences and some of us in clinical sciences, and appreciate the long-term mortality of certain inflammatory diseases in order to make appropriate decisions here, especially when dealing with debilitating diseases such as multiple sclerosis and chronic inflammatory arthritis and other autoimmune conditions. A few weeks or months of antibiotics is low risk and potentially high efficacy for patients who might otherwise suffer for decades and die prematurely from potentially treatable inflammatory disease. So obviously that conversation goes back into risk-benefit ratios. A lot of doctors might say, for example, oh, well, the research doesn't really clearly justify using antibiotics for the treatment of chronic arthritis or for multiple sclerosis. But I think we could look at that from a different perspective, and we could ask, perhaps we should ask, well, what's the long-term risk of not doing this and leaving this patient in their debilitated and inflamed and autoimmune state? That also carries some risk. So what's the risk of not treating this patient as compared to a few weeks or a few months of antibiotics to see if they respond? So those are conversations we can have with our patients, and we can say, look, the data on this might not be crystal clear, but we could also give this a try and see if you respond in a way that's favorable. Because, in a lot of these patients with drug-resistant autoimmunity, if we don't offer something, then we're kind of relegating those patients to their inflammatory diseases. And obviously those have major consequences, not simply for joint pain and immobility, but also for cardiovascular disease, renal disease, etc. So again, I think we have to look at the risk-benefit ratios. We have to get into conversations with our patients and engage them on the strengths and limitations of the research. Say, look, this might not work, but if you're willing to take a chance that it may work, and we appreciate the risks of antibiotic therapy, then I think we can make informed decisions and move forward with some level of confidence, and a level of confidence that's even appropriately defensible if called into critique by a medical review board, for example, and I'll show you that data as we go through. So here's an excerpt from an article that I published back in 2006. So this was 10 years ago. I just want to read this. It kind of supports what I just said. One of the problems that plagues many healthcare providers of all professions is that most doctors are still under the spell of what I call the Pasteurian paradigm of infectious disease, namely that pathogenic microorganisms cause disease by causing quote-unquote infection. We now appreciate dysbiosis. We now appreciate colonization. When I wrote this article 10 years ago, we were still needing to justify dysbiosis. Dysbiosis wasn't a term commonly used. And so what I was doing with this article in particular was helping people to kind of get past their infection-based associations with certain microbes and get them to look beyond that and to appreciate these dysbiotic relationships. Relatedly, as I state here, Koch's postulates, first published in 1884, held that the organism must be found in all animals suffering from the disease, but not found in healthy animals, and furthering that quote, the cultured organism should cause disease when introduced into a healthy animal. Now we see with dysbiosis, we're talking about combinatorial effects. We're not simply talking about one microbe causing one disease. We're talking about combinations of microbes. For example, in the sinorespiratory tract, the gut, and the genitourinary tract, leading to combination effects that ultimately can produce these autoimmune diseases. A good example of that I mentioned previously are certain vasculitic conditions, such as, for example, antiphospholipid antibody syndrome, where we see multiple microbial contributions to that pathophysiology. The major problems with the models proposed by Pasteur and Koch are that both of these models fail to appreciate, number one, adverse microbe-host interactions, which may not result in nor result from a true infection, and number two, the importance of the patient's biochemical individuality, including, of course, their nutritional status and genetic uniqueness, which results in the observed phenomenon that not all patients exposed to a particular microbe will express the associated disease. So, for example, I recall in my clinical practice around the time that I wrote this article, seeing many patients, for example, with Klebsiella pneumoniae within their gastrointestinal tract. Some patients felt fine, others had kind of an irritable bowel syndrome picture, others had chronic fatigue, others had inflammatory arthritis, all triggered by, in my opinion, the Klebsiella pneumonia that was in their gut. So we see divergence and we see kind of different disease patterns associated with these microbes based on the patient's genetic susceptibility as well as their nutritional status. Supported amply by the research reviewed herein, healthcare providers have an obligation to move beyond these primitive pathogenic and infection-based disease models of microorganism-induced disease to apprehend the more common functional disorders that can result from exposure to microbes. Again, this was published by me back in 2006. You can download the full text of that article. It's been one of my most popular articles. I think it's been downloaded more than 5,000 times. Here's what we're going to focus on today. We're going to talk about microbes, disease, assessments, and interventions. We're going to talk about chlamydia pneumoniae associated with persistent fatigue, multiple sclerosis, inflammatory arthritis, and one of its first associations, of course, was with atherosclerosis and cardiovascular disease. From a medical microbiology standpoint, we, of course, associate chlamydia pneumoniae with pneumonia. It typically causes pneumonia in older patients, especially older alcoholics. That's one of the classic associations. But now we're seeing, of course, other associations, whether overt disease or syndromes, we might say, of chronic fatigue, again, multiple sclerosis, inflammatory arthritis, and atherosclerosis. One of the ways that we can assess for this clinically is to do serologic testing for the IgG titer against chlamydia pneumoniae. I'll show you the data supporting that we can look for a antibody titer of greater than either 1 to 64 or as high as 1 to 256. I'll show you an example from my clinical practice on that. I'll also show you some of the data supporting that specific number. Interventions we can use here include azithromycin with or without rifampin. Rifampin, I kind of think of rifampin as hamburger helper, so to speak, for other antibiotics. It's a weak antibiotic on its own, but rifampin's real benefit appears to be helping to potentiate other antibiotics. So azithromycin has some benefit on its own. If we mix azithromycin with rifampin, adding the rifampin helps the primary antibiotic, we might state, to work better. Moving into the second category, we're going to talk about Streptococcus pyogenes. The classic disease association with Streptococcus pyogenes is, of course, strep throat, secondary rheumatic fever. In this case, we're going to talk about Streptococcus pyogenes and its association with psoriasis, also obsessive compulsive disorder, and certain neuropsychiatric syndromes, especially in kids. The assessment here, I think, is more empiric, even though, of course, we can use serologic testing. Basically, we've got 3 or 4 good blood tests that we can do for Streptococcus pyogenes activity, but you'll see that some of the data using antibiotics, presumably targeting Streptococcus pyogenes, has been clearly empiric with no lab tests performed at all. Some of the antibiotics we can use against Streptococcus pyogenes include penicillins and, again, azithromycin. For blood dysbiosis, we see the strongest association here in patients who have diabetes mellitus type 2. The assessments that are used are research methodologies that really are not available in our clinical practice. So one of the things we can do is just treat empirically and monitor response to treatment. For example, we can use berberine, we can use probiotics, but berberine really seems to shine here in the treatment of diabetes mellitus. I'll show you a few studies in that regard. So let's start by taking a look at chlamydia pneumoniae, again associated with persistent fatigue, multiple sclerosis, inflammatory arthritis, atherosclerosis, and cardiovascular disease. We're going to go through those disease associations first, then we'll look at the research supporting the interpretation of this IgG titer and then we'll talk about the use of azithromycin and rifampin. So here's a review article from Trends in Microbiology. This is January 2003, Cellular Paradigm of Chlamydial Pathogenesis. So when we talk about chlamydia as a class or as a group of bacteria, we're typically talking about Chlamydia trachomatis and Chlamydia pneumoniae. In this particular conversation, we're going to focus on Chlamydia pneumoniae. As you can see in the first sentence of the abstract, the author states that diseases caused by chlamydia are based on intense and chronic inflammation elicited and maintained by reinfection or persistent infection. Let's move on from there and take a look at this article. Chlamydia as etiologic agents in chronic undifferentiated spondyloarthritis. So what I did very briefly there was establish that chlamydia can create or persist as a chronic kind of smoldering infection. This article associates chlamydia with undifferentiated spondyloarthritis. Let's look at the summary. Frequency of chlamydia-positive synovial tissue samples as determined by PCR. So again, that's obviously not something you're going to do in your clinical practice. Frequency of chlamydia in synovial tissue samples determined by PCR was found to be significantly higher in patients with undifferentiated spondyloarthritis than in patients with osteoarthritis. Our results suggest that many patients with undifferentiated spondyloarthritis, chlamydial infection, which is often occult, may be the triggering inflammatory cause. You can see that this was published in 2009, Arthritis and Rheumatism, obviously a very authoritative journal. So what we're associating here is the chlamydia persistent infection with undifferentiated spondyloarthritis. Let's take another look. Now associating persistent chlamydia with chronic arthritis. So not simply arthritis in the spine, but also peripheral arthritis. I'll introduce this article simply by reading the abstract. Urogenital infection with Chlamydia trachomatis can lead to the development of an acute inflammatory arthritis, and this acute disease becomes chronic in some individuals. That is what I've mentioned several times before, which is reactive arthritis. Research indicates that the organism is present in synovial tissue of patients with chronic disease in a persistent rather than an actively growing form. Importantly, metabolic and other characteristics of persistent chlamydia differ from those of actively growing bacteria. Other studies suggest that Chlamydia pneumonia can be found in a persistent state